A lot of this information is a review for many of you, but feel free to interrupt with questions. I want it to be a little informal if that's possible over Skype. I'm not sure. But go ahead and throw out questions at any point. Okay, so next slide, or first slide, I guess. So first things first, talking about opioid use disorder and what medications. Perfect. And what medications there are used for opioid use disorder. Again, as a review, there's the 3 FDA medications that are approved. The link on the top gives you, will send you to that handout that's right there that talks about using medication to treat opioid addiction if you wanted to hand that out or needed that. Mallory, do you see there's some people?
Yeah, I'm trying to work through that right now.
Okay. So the first medication that we're going to talk about is naltrexone, and many people know naltrexone as Vivitrol. And Vivitrol is mostly used in North Dakota as a monthly injection, and that can be prescribed by any physician. So there's no special training a doctor needs, or it doesn't need to be at a specific clinic. Any doctor is able to prescribe that. So there isn't, I mean, some doctors may not be as familiar with it, but there's resources to help with that if an individual wants to get on naltrexone. One thing with naltrexone is that an individual must not have any opioids in their system, because once the injection occurs, individuals will go into immediate withdrawal. And so usually the population that works best with this is someone who is either residing in a correction facility or have been in an abstinent-based treatment, residential treatment program, and not used anything for, I believe they say, 7 to 10 days. The next medication is buprenorphine, also known as Suboxone. That is, so I'm going to, if you want to flip to the next slide, and it'll tell you where you can find resources for buprenorphine.
Is this the right one, Lucretia?
Yes, that's it. So you can see at the very top there's a link that you can click on, and that will take you right to our behavioral, the highlighted one that says buprenorphine treatment physician locator. And when you go into that site, you can see what prescribers have been approved to prescribe buprenorphine, their locations, and their telephone numbers to be able to get a hold of them. One of the things for buprenorphine is prescribers have to have a specific training called the Data 2000 waiver, and so before anyone can receive that, they have to find a doctor that prescribes or that's received that training. Then, as just kind of a side note, OBOTs, if you hear the word OBOTs, that is office-based opioid treatment. And so across the state, there's several OBOTs that have opened. That is the only thing that clinic does, and so that's what that is referring to. So next slide is going to talk about methadone for the use of opioid use disorder. The only way that methadone can be prescribed for opioid use disorder is through an opioid treatment program. And there we go, next slide. So methadone, so the opioid treatment programs, there's 3 in the state. There is, let's see, whoever asked that, we're on slide 4. Perfect, thanks guys. So, okay.
Lucretia, just sorry to interrupt, just 1 second. When I hit next, there's a real noticeable lag when you see the next slide. So just so you know, that's kind of why it's showing up slowly for you.
Perfect. So there's 3 opioid treatment programs in the state. There's one in Bismarck, that is Heartview, and then there's another agency that has 2. One is in Minot and one is in Fargo. So you can hit the next slide. That same web page will bring you to a link where you can find their phone numbers to access if you have individuals that are looking for that service. So the next slide is going to talk about what happens, what occurs in an opioid treatment program. For folks that call in, they will have an appointment scheduled, and within the first appointment, they will meet with a doctor and have a complete physical completed. They'll talk about the options that there are. Was there a question? An online meeting? Okay. No? Okay. I'll keep going. So, there we go. Okay, so initial appointment, individual will come in, have a history and physical. They will meet with a counselor. If the program has peer support specialists, which they're all working on getting peer support specialists, and then they're able to dose that first day if everything checks out and the physician or prescriber is okay with that. So that's really an amazing thing that it can happen that exact day. In the opioid treatment program with methadone, individuals will need to go to the opioid treatment program daily to receive that medication dose. They meet with a nurse. The nurse will have conversations with them, make sure that the medication was taken, that they're tolerating the medication okay, or if there's concerns where they may still be experiencing withdrawals and struggles, and needing that medication increased. So those are some of the pieces within opioid treatment program. Okay, next slide is one of the things that, so we have opioid treatment programs, great, that's really exciting for North Dakota, but we have 3 of them, and their locations are, very spread out. And so one of the ways that we were looking at how to increase access was looking at medication units. And so this handout is really talking about what is an opioid treatment program, what are the, who is the regulate, how is it regulated between state and federal, and so that's the first column. Second column is medication unit, and what exactly is that? And then the third column is something called the mobile methadone unit, and that's something that some states have, but the DEA is no longer allowing that. But we wanted to include the information because people were confusing what a medication unit was versus a mobile methadone unit. So during this past legislative session, we went forward and asked for the authority to regulate medication units, so that will increase access. So say you have a program here in Bismarck, you have Heartview, and we wanted to look at increasing access to folks in Jamestown. Heartview would have the opportunity to have a medication unit open in Jamestown. It would have to be in a secure location. The DEA still comes out and does a review. There is specific requirements underneath that, but that medication unit is kind of an off-site of the opioid treatment program. So no medication unit can open on its own. It has to have an OTP attached to it. So that will hopefully provide some other opportunities to increase access to methadone for individuals across the state. Okay, so that's all I have on opioid treatment programs and the medication that treats opioid use disorder. So if there's any questions, feel free to unmute or throw a message up, and I will keep going. Yeah, so I am now on naloxone. And Mallory, I can actually hit it and make it
Oh,
switch.
well
So,
then, yeah, you go for it then.
okay.
Thank you.
Yes. So the next conversation is about naloxone, and hopefully all of you have naloxone and carry it on your person, have it available for you. If you don't, please talk with your coordinator in your community, and they can contact those here at the division to make sure that you have that available. So naloxone, of course, is the medication that can temporarily reverse an overdose. I believe everybody on this call is received the actual training to administer it, but I wanted just to touch base. So naloxone is the generic name, and then there's the three formulations of naloxone that are FDA approved. So the first one is Narcan, and that's the nasal spray that I believe everyone on the call has access to. And then the next one is Evzio. That one is a voice-activated injection. And then the injectable, and that is, that is more for like ambulances, and that's what's provided at syringe service programs. So they're providing clean needles, syringes to individuals, and so they will give them a vial of naloxone injectable for availability. It's a much better cost than Narcan or Evzio. One of the things with Narcan is there is a expiration date, and if you were part of the first crew that was trained, the Narcan that you have may be getting close to expiration. There has been information that has come out that says Narcan may still be effective up to 9 months after the expiration date. So don't throw those out. Those still could be can be used if necessary. And then, like I said, get a hold of who your FTR administrator is in your community, and they can get a hold of me if more is needed. So accessing naloxone, this again can be done. A physician can write a prescription, local pharmacies can write a prescription, which is really exciting. Not a lot of states have that where pharmacies can write the prescription, so that's really a great thing that we have to increase access. The law has been written that anyone that's carrying it, anyone that uses it for a suspected overdose is protected from any civil or criminal liability, and so that sometimes concerns people when they're carrying it, that there could be an issue, but naloxone itself is covered by that law. Next one that's very, very important is the Good Samaritan Law. This really is put together to encourage individuals to call 911 if they're with somebody that has an overdose, or they're a suspected overdose. That's the word I was looking for. And there has been some areas in North Dakota where when I say this, they come back and say, well, that's not how it works in my community. We are working on that. We're aware of some areas where that's not working, but we still want to encourage this law. And when I say not working, I mean where some law enforcement are still giving that as a charge, but then it's dropped later on because of this law. But that is occurring in some communities, based on where you're located, but know that is being worked on. And if you're coming across that, or people say that, that would be a really great thing as well. That can sorry, I'm distracted. So
yeah, it looks great. I think that I think when you hit next, it's only for you. Yeah. So I tried to catch up based on that. So I think we're on the right one. I think it's slide 10.
So I am on slide 11 now, Good Samaritan Law.
Okay, we're good. We're all caught up. Just let me know when you want to switch again.
Okay, all right. Good to know. Okay, so if there's conversations or there's word that that's happening, again, and you have conversations with the FTR coordinator in your community or FTR administrator, let them know, because they can inform us, keep us updated here in working on that and working with local law enforcement that to make that so that doesn't happen. Okay, so the next slide is an example of what we're doing with some of the funding that we received, so other resources or other things that are occurring. The first one is quick. It's 1RX, and that's a program through NDSU, and they have gone out and trained local pharmacies to screen individuals that are receiving an opioid prescription, screening them for where they are on their risk of having an overdose, although we know anybody can have an overdose if they're prescribed or taking an opioid. And so then they also give education on the possibility of not filling the whole prescription, but doing a half fill or taking a prescription for naloxone. So that's very exciting that that program is available. Slide 13 is talking about our Stop Overdose campaign. On our website that's listed there, there's a lot of resources that individuals can go to depending on what your profession is. So there's resources for doctors and behavioral health providers and family members on there on what to do for an overdose. What does it look like? What are some options outside of, just policy changes and other things that can be helpful in the fight on stopping overdose. Okay, next one is slide 14. Is another campaign that is here at the Division for Opioid. It's Lock, Monitor, Take Back, really looking at keeping medication locked in an insecure place, tracking how much medication it is, and then the Take Back program, which is through the Attorney General's Office and the Board of Pharmacy. And so there are most law enforcement agencies and several pharmacies have the ability to take your medications to drop them off. So that decreases access for people to abuse prescription medications. So on that slide is a link that can take you and show where all of the locations are across the state. And then one of the last efforts that I'm going to talk about today is the next slide, slide 15, Syringe Service Program. So this is something that's regulated through the Department of Health, although we have worked closely with them on pieces within getting them set up. So there are, I believe, 3 that are functioning. I'm speaking off the hip because it's been a while since I have been in conversations, so I believe there's 3. If there may have been more that have opened since then. So this is for individuals can access syringe services, and it doesn't only mean that they can go in and get clean syringes. There really is an engagement to the service as well. So developing professional relationships and rapport with the professionals and the individuals, and using motivational interviewing skills to increase their readiness to make changes in their life. So it's very exciting. I love that North Dakota has this. It's a great opportunity to reach people that sometimes we wouldn't have opportunities to reach. So it's really great. All right, so in a nutshell, that is all I have. And so if there's any questions, anything that's come up, I am absolutely available.
Thanks, Lucretia. Yeah, if you think of something, and if Lucretia hops off and you think of something towards the end, like, feel free to shoot us an email, or even Lucretia an email, or you know, you always can ask a question in the chat box as well. So we'll give a couple minutes here, or not minutes, a couple seconds if anyone wants to speak up and ask a question while she's still on. Nothing?
All right, yay, I'm off the hook. I'll probably stay on for a few more minutes, and then I'll jump off. But thanks for letting me come in and talk.
Yeah, thanks, Lucretia. I'll go ahead, just bear with me for a couple minutes. I'm going to switch over into my PowerPoint presentation. Oh, we got a question here, Lucretia. You could maybe answer that in the chat box while I get mine pulled up.
Okay, I saw the question pop up, and then I was trying to go in to see if I could answer it through that, and then I lost it. So the question was about Subzol, and that's a brand of buprenorphine, I believe. So I'm not a nurse, and so I don't know much more than that. It would have to be, if it's a buprenorphine. And if anybody else is on that is a nurse or knows, please. But I'm gonna, let's see what Google tells me. Yeah, so Subzol is considered buprenorphine, so it would be within the same locations that a prescriber that has received that Data 2000 waiver training, they would be able to prescribe. Yeah, absolutely. And one of the exciting things too is before we had received the grant funding, we had, I believe, 18 prescribers in North Dakota that had completed the training. However, less than that, several less than that actually what we're prescribing. And so now, since our funding and some of the efforts that we have, there's between 50 and 60, and several of them are actually prescribing. So that's something that's really exciting.
Great. Thank you. Okay, so if there are any other questions, like I said, feel free to list them in the chat box or shoot any of us an email. We'll dive into the second half here, and I want to kind of save some time for the opportunity for questions or discussion at the end as well. So yeah, the second portion of today's content is on general crisis response. I think we've had, obviously we've been up and running now for a year, so we're more than aware that you as care coordinators and peer support specialists have come across individuals or participants in the program who are actively in crisis. And so we know that sometimes that involves, substance use. Like, that's kind of why we wanted to present the information that Lucretia had. And then also we know that that might not pertain to substance use. It could be mental health concerns or job loss, things like that. So we'll kind of dive into that right now, and what crisis is, how people interpret crisis, and then what you as a care coordinator or free to recovery staff can do to help someone who's in crisis. So crisis, defined, is an event or situation that is perceived as problematic by an individual, in which goes beyond their available resources and or coping skills. So as you can see, this definition leaves a lot of room for interpretation for the individual who's experiencing it. So, and I'll kind of get into this in the next slide, but, what might be a crisis for someone would not be for another person. So it's important to remember that there's an element of subjectivity in how someone perceives and copes with crisis. Moving down there at the second half of the slide, free to recovery participants will obviously experience various types of crises, and we know that they already have since we've been up and running. So crises can pertain to substance use, mental health, loss of a job, domestic violence, eviction, divorce, or death of a loved one. Substance use, that could look like something like an overdose, or a crisis related to substance use could look like something such as an overdose or maybe relapse. For mental health, it could be a suicide attempt or maybe increased thoughts of suicide, or maybe an increase in psychotic or manic symptoms. And it's probably worth noting that this certainly isn't an exhaustive list of crises. I think, like I said, it kind of depends on who you ask and who's experiencing the crisis. But it's probably worth noting that a lot of, crises are intertwined. Like someone loses a job or someone, has someone who's close to them who passes away, that person may kind of spiral into increased substance use or mental health concerns.
Hi, Mallory.
Yeah.
Sorry to interrupt you, but I'm still seeing the syringe services program slides. I'm not seeing the slides that you have. I think it's still on Lucretia's. Is everybody else seeing that?
So is everyone seeing the crisis response slides?
I see the crisis response slide. This is Lucretia.
Okay.
I see this one. We're on number 2, right?
Yep. So Pamela, I don't know if you want to maybe X out and join back in. I don't know if your computer froze or what. So we'll jump back in. So we are on slide 2 of 11. So I was just wrapping up my thought there. Just a reminder that a lot of these crisis areas can be intertwined and can kind of one thing can lead to another for a lot of folks experiencing crisis. Now I'm on slide 3. So like I was mentioning, how a crisis is perceived can be specific to the individual experiencing it. So what is a crisis to someone may not be to someone else. So for example, if 2 individuals are laid off from the same employer, it's worth noting that the resources available to each individual and their coping skills could look very different. So, someone might have a list of networking supports where they could go and start looking for another employment opportunity, whereas the individual who maybe doesn't have those resources or those coping skills would maybe struggle with, isolating themselves, not getting out of bed when they lose their job, or so it's worth kind of keeping in mind that what might not be a crisis to you could certainly be a crisis to someone else. And then just how someone perceives a crisis, same thing. Similarly, how individuals cope with crises can vary significantly. So something that kind of came up when I was putting these slides together is a mention of adaptive and maladaptive behaviors. So adaptive behaviors are kind of defined as how an individual, they may experience hardship or crisis, but they kind of walk through their coping skills and they develop adaptive behaviors. Like if someone has a death of a loved one, they might know that they need to call their therapist and see if they can increase therapy sessions over the next couple months. Whereas someone else could turn to maybe substance use or isolating or an increase in mental health symptoms and not reaching out for support in the community. When I was kind of reading through adaptive and maladaptive behaviors, I want to kind of mention though, I often, when I meet with clients in the prison, I often remind them, how that regardless of how a participant responds to a crisis or their life circumstances, they've gotten this far, and it's just about how it can be done in a healthier way. So I kind of say, sometimes our clients do what they need to do to survive. And so I think that's worth mentioning that, you're here and that's great, but let's figure out a healthier way to do it next time. So now I'm on slide 4. So this quote just kind of stuck out to me, and I wanted to kind of include it. So prolonged stress may have exceeded their coping capacity and usual problem solving so much that they are unable to effectively handle the stressors. I pulled this from a textbook of mine, and it was used in a way where they kind of put it as keep in mind, people, there are people out there who can't cope. And I just thought of our Free to Recovery participants, because the majority of our folks have gone through not only prolonged stress, but traumatic events in their lives, whether that be as part of a person in the criminal justice system or out there living in the community or maybe past experiences. And I think a lot of our folks would kind of fall under this quote. So it just kind of stuck out to me and something I wanted to include in the presentation. So I'm on slide 5. So this is kind of where we shift into, what your role as a care coordinator can be for someone who's actively in crisis. I think the first thing that we need to do when you kind of come up on, a client who's maybe experiencing a crisis scenario is define what the problem is. It's very important that both the participant and the care coordinator have the same understanding of the problem. I think there's really at the root of that is it's going to be difficult to resolve a problem or a crisis if the care coordinator and participant aren't on the same page. I think oftentimes we see folks on our caseload who they are certainly struggling and maybe not willing or in a place where they feel like they want to, address the problems that are right in front of them or maybe that we see and that are very obvious. I know I've had a client in the past who was couch hopping, engaging in risky behaviors, and was engaging in really risky drug use. And I couldn't do anything about that because she wouldn't answer my phone calls. I only really heard about this through a family member of hers. So it's really tough when you see someone who's in crisis, but they're not really at a place to want to address that. So just kind of keeping that in mind. But in the event that you both have an understanding of the problem and your participants willing and able to address that crisis, kind of that's where we're kind of moving in the direction of for the sake of this training. So outside of defining the problem, I think the next and most important step is client safety. Can the participant keep him or herself safe? I think that's a huge question, and sometimes a question that when we get the answer, it's hard to know what to do next with that. So I wanted to kind of note here something about crisis plans. I don't know if a lot of our providing agencies for free to recovery use crisis plans or safety plans or contract for safety with their participants, but it's something I think we should all consider. And worth noting that after the presentation today, we'll send out some pretty standard templates for a safety plan or for a crisis plan that you guys could potentially use to form your own crisis plans for your participants. These templates that we'll send out just come from the National Suicide Prevention Hotline. So, and I don't know if Lucretia, if you're still on, if you have any templates as well or any resources on that, but that's certainly something we can provide to everyone. So getting back to client safety and the safety plan, I think something we need to think about right away is if someone can't keep themselves safe, if they have a plan to harm themselves, you need to, as a care coordinator, make that decision if 911 needs to be called or if they need a ride to the hospital. I think oftentimes, and it will happen in the future where clients certainly display serious enough behaviors where they need attention right away. And knowing that it's okay and letting the client or the participant know that it's okay to contact 911 if they are fearful that they're going to harm themselves or someone else. So keeping that in mind, and I know Dr. Peterson has told me the example in the past where she was meeting with one of her clients in her private practice setting, and his suicidal thoughts were serious enough that she walked him across the street to the hospital. So I know that there are cases like that where sometimes we have to drop what we're doing and help facilitate, their safe transfer to a hospital setting. So getting into the crisis plan, something I think that is really helpful for clients is just writing down, what does it look like when I'm having a hard time? What does that look like for me? And writing down some of the the symptoms, their feelings, their thoughts, things like that come up when they're having a hard time, when they're in crisis. So kind of getting that on paper, and then what they can do to ease some of that in the moment. So if there are activities that they could take part in or things that they know calm them down, people they can call when they're having a hard time. And then there's kind of like the next steps, like what services are in the community that you can help give them and that they can write down where they can call if they're experiencing suicidal thoughts. I know the Human Service Centers is something I put in there just because I know that those exist. It's in each region of the state. I'd be interested to hear towards the end of the presentation if there's any really great like suicide or crisis resources in your area. So something to keep in mind on that. So again, we will send out just some really simple templates on crisis or safety plans, something for you guys to kind of use and maybe work towards developing a safety plan for your agency to use for participants. So I'm on slide 6. Moving into, what your role is as a care coordinator, as a peer support specialist with folks who are in crisis. So you will likely find yourself with increased contact with participants and other service providers. This could be in person, over the phone. Maybe you're exchanging text messages more often than usual. I know lots of our providers use Facebook Messenger. Just expect that it's going to be a bit more time consuming from your end when someone is in crisis. You might find yourself meeting with them at their home, or if they're hospitalized, you might meet with them at the hospital, maybe at a homeless shelter. And again, you might find yourselves like meeting in places where you don't typically meet just because the person isn't at their baseline. They're not doing as well as they normally are doing. I think along with increasing contact with the participants, we also need to keep in mind that we need to keep all the folks who are working with them, I guess we could call that the care team, informed of what's going on if they don't already know. And an important nod here to releases of information. At the end of the day, you can't share anything, about someone if you don't have that person's permission to do so. So when I say that you should be informing the supervision officer and other appropriate collateral contacts, that's assuming that there's releases of information involved in that or consent from the client. So I think just a reminder and to tell you it's okay that you may meet multiple times per week with participants who are in crisis. And that might be, intentional on your part. You might say like, okay, we're meeting today. Normally we'd meet next week, but because, you're having a hard time, I'll give you a call tomorrow to check in, but then we're going to meet the following day in person just to check in person as well. That's really important in those times to kind of set the expectation that, you're here, you want to help them get through this difficult time and work through that. And increased contact will certainly help with that.
Mallory?
Yes.
This is Elliot.
Hi, Elliot.
I have a question as it regards this topic.
Yeah.
Is it probation's responsibility to let us as care coordinators know a client's mental health status or situation after they visit with them, or where can we find that information?
I wouldn't say it's necessarily their responsibility. I would hope that if there's any evidence of like deterioration or someone's not doing well and they know that the officer should call and let people who are working with that individual know. I know there's been some, and this is another topic for another time, and we're kind of working on it in the background, but there's been some discussion around some new releases of information directives that parole and probation has received around what information they can share about clients pertaining to substance use. So just know that, as someone who's working a part of a care team, there should be that exchange of information, but with the caveat that we know there's a little bit of like just some stuff we need to work through with them feeling that they can't share certain information with care coordinators. So yes, I don't know that they're technically responsible, but they should be part of the discussion, and letting others know on the care team if there's concerns with a client or a participant that they're working with. Does that help, Elliot?
Yes, it does. I have limited contact with probation as far as like what it was the result of their meeting. If I inquire, they let me know when they met with the client and when the next meeting is. I have to inquire all the time because I don't know where to go to find out the exact date. But to the topic of how they're doing, because I have some people who are fragile. And I never know really what was discussed in the probation meeting, if those issues were discussed. And my only opportunity to find out about it is if I get in contact with the client and they'll share with me what they shared with probation, if at all, because they have no obligation to share anything with us, nor obligation with probation, but they might be more apt to share it with them. I don't know. I don't know about that. You're more attuned to that, but I'm just wondering, how do we find out, what went on in that meeting, and if it would be helpful, if that information would be helpful for us to do a better job in communicating with the client and what their needs are. I guess that's my question,
Yeah, and I would say yes, it definitely would be helpful. If you find out of a meeting that a participant had with their officer, and you have a feeling that information, they might just have information that could help fill in or like in between the lines. I would say certainly just give the probation officer or parole officer a call and just say, hey, I know you guys met, just want to get your take, your perspective on your meeting. How do you think she's doing or he's doing? So you can certainly call and inquire about that as well. But I think with anything, this is kind of a learning experience. I think free through recovery is something that it didn't exist before. So a lot of times we're minding officers, you can certainly reach out and let the service providers in the community, including free through recovery staff, that that they should maybe know something that they were informed of by the participant.
Thanks, Mallory.
So, yeah. Okay, so then moving on to the second portion there on slide 6. So focusing on when you're sitting down with someone and you're working through a crisis, if someone gets evicted from their apartment, and you're sitting down with them to figure out what's the next step, it's really important to focus on specific and targeted interventions to address the crisis at hand. So identify the specific tasks that the care coordinator and the participant will each take to address the problem. This is where I kind of want to mention, you might have participants who are actively in crisis who might not have the ability or the skill to make phone calls or to follow up on things or to fill out paperwork, when they're having a really hard time. And that's okay. I think there is a level of workload that increases a little bit as providers or care coordinators or peer supports when someone's in crisis. So involving them as much as they're able to be involved in. So certainly if someone's motivated to get this problem resolved, and they can make calls to various landlords or to resources in the community about funding, you certainly can include them in that. But just know that it might be a struggle for them to kind of do some of that legwork in that moment in time. But those responsibilities and those tasks can definitely shift back over to the participant once things kind of level out and you're kind of coming out of crisis mode. So establish a time frame for both the care coordinator and participant to complete established tasks. If you're going to meet with them in 2 days again, write down, by we're meeting on Monday, by Wednesday you're going to have these 3 places called. I'm going to look up resources on the internet for you, and I'm going to make these phone calls, and we'll come back together on Wednesday to talk about the progress that we've made. So, really set those short-term goals and those tasks that can be completed and kind of help move things in the right direction on a very short scale time frame. Ensure the participant's point of view is reflected in the established action steps. Just because someone's in crisis doesn't mean their perspective of things or their preferences should be removed from the solution or the moving towards the steps taken to the solution. I think it's really important that we still utilize those motivational interviewing strategies and the spirit of MI when we're working with someone in crisis. So be sure that that the participant's on board with where things are at, and if they're capable, let them kind of steer the direction in a way that solution is going to be really specific to them and their needs. I just said short-term focus on solutions to resolve the crisis scenario. We kind of already touched on that. So I'm just looking here at my notes in case I forgot something, but I don't think I did. So we'll move on to slide 7. So this is important, documentation. I know our last training that we did was on documentation, and Dr. Peterson presented some information on this. And this is, again, really important. I kind of took the structure of a case note from those exact slides that she used when she presented. So this might look a little familiar. The only thing that I changed was you'll see the middle bullet point where it says provide progress update on tasks being accomplished. In any other existing case note, you might not, you might be focusing on like longer term goals and progress on goals, but when you're writing a crisis note, it's important to kind of like recognize that you're probably not going to, if someone's in crisis and they got evicted, you're probably not going to continue working on in that moment getting them into a GED program. It might not be the best time. So really focusing, having a narrow focus on your documentation when you're documenting crisis notes. Pretty much everything is the same other than that. It's really important to describe the person's mental status and your behavioral observations. It's really important to, this is your time to also like document what you've done and what you've helped with, what resources you've given the person, kind of work on just making sure that whoever's reading that note that, you provided the services or those resources to the individual when they may not have known where to turn to otherwise. And then the plan for follow-up, again, like, I'm going to, for example, met today on Monday, I'm going to give them a call tomorrow just to check in, and then we're going to meet again in person on Wednesday to continue addressing the tasks that we identified. So being really specific, and I know this was something we mentioned in our last one, but actually following through on that note. If you say you're going to meet in 2 days or you're going to call in a day, get that note in right away, especially if someone's in crisis, because, it's a little bit more of a time-sensitive note than any other case note. So just something to think about when documenting crisis scenarios for individuals. I'm on slide 8 now. So just keeping in mind, I mentioned this, you as a care coordinator or peer support may find themselves completing more tasks than usual, whereas not in crisis. This is okay, and I don't think, I don't want, care coordinators or peer supports or any service provider for that matter to view that as enabling. A lot of times when clients, like specifically in free to recovery, when they've experienced crisis, they've turned to behaviors that have certainly helped them survive, but they're not healthy choices. So, drug use or things like that. So the point is, and the whole point of care coordination is to kind of walk alongside with them. And there will certainly be times where you have to do more work, and crisis is one of those times. Identifying the silver lining after a crisis is resolved. I always say to folks I'm working with, you got through a really tough scenario, and you're sitting here in front of me today, and you're able to talk about that. What did you learn from that? What skills did you use? What skills did you acquire from that? I think a lot of times when we can really utilize a strengths-based approach in how folks deal with crisis is incredibly important, and it empowers them to know that, when something like this happens again, or when something bad happens to me, I'm capable of getting through it in a way that's healthy and keeps me going. So welfare checks and hospitalization. Wanted to quick touch on this. Don't be afraid if I haven't done many of them in my case management careers, but I have done a few. If you go to a door and you have a reason to be concerned and they're not answering the door and you're worried, potential overdose or someone might have hurt themselves, don't be afraid to call the police and ask them to help you do a welfare check on them. I don't know if anyone's done that yet. I know I've done it in the past, and both times I've done it, the person has turned out to be fine, and they're actually annoyed at me for calling the police. But that's okay. In that moment, I was very concerned for them, and I had reason to believe that, that something was wrong. So it's great that it wasn't, and it's also okay that my client was annoyed with me, but I just expressed, I was very concerned for you. These last few weeks have been tough, and I just wanted to make sure that you were okay. So something to think about if you really feel like that's necessary and you're genuinely concerned for the individual. And again, hospitalization. Sometimes people just really need that intensive of support. They need to go to the hospital, or they need to be, walked. I misspelled bringing. but they need to be walked over to the hospital or driven there, or, you know, if you don't feel safe bringing someone, if they're under the influence, and they have a history of, you know, pretty intense mental health symptoms, and they get worse when they're using, you know, certainly don't put yourself at risk. You can call the police for transport, or, you know, but just utilize those services if you feel like they're necessary, if the participant feels it's necessary. I think a lot of, including myself, I have this like fear of calling 911 and it not being an emergency enough. And I think we need to tell participants, like, hey, if you have a plan and you really think you're going to hurt yourself or someone else, you need to call 911, or I'll call with you, you know, that type of thing. So those are just kind of some last tidbits that I wanted to touch on. I don't know that we'll get into this right now because we're kind of running short on time, but really it was just an example of like a crisis scenario that I wanted to run by you guys. You know, it was just an individual, kind of like a hypothetical, and a care coordinator stops by a client's house. His mother just passed away, and he's feeling more depressed throughout the night and into the day, and has had some passive thoughts of suicide, and is wanting to turn to drug use. So, in my mind, and I hope in everyone else's, this is a crisis scenario that needs to be addressed. And so that was kind of going to be our conversation, is around how to address that. So just something to kind of think about, and kind of applying this situation to what we talked about in the previous slides. So we only have about 7 minutes or so left, but I wanted to, hear from you guys. I'm certainly, and I know Paula, the regional admins, you guys too, I don't have all the answers for crisis resources. I know Lucretia touched on some of that in terms of opioids, but I'm wondering if anyone wants to speak up or to, make note in the chat box about any resources in your community that you find helpful for crisis scenarios. No? Pretty quiet. Here we go. 211 in Fargo.
Yeah, this is Pamela. Solutions came to our meeting our last meeting and shared about their crisis intervention team.
That's great. That's a great resource.
And anybody who wants to know more about it, let me know and I will forward that on. I just wasn't prepared to speak about it because I don't even remember what it was called right now, but they do have it here in Fargo. And I believe that there's talks about wanting to have it in other regions too.
That's great.
This is Carolyn with Solutions. Yeah, I brought Brandon Germain, who oversees our mobile crisis programming, to our meeting last time. It's essentially region, was it 5, I think? I can't remember the number on the region, but
yes.
It covers Cass County and the surrounding regions. And essentially what it is it's not our program, it's a program run through Southeast Human Service Center. They cover crisis during the daytime hours, and they contract with us to cover them evening and weekends and holidays. And so it's a direct call. There's a number direct call to Southeast, and then they dispatch us at that point if it is during those off hours. And so we work a lot with law enforcement. We're in the hospitals, things like that, trying to prevent hospitalization. So the Fargo team got a pretty good feel for it, I think so.
Great, thank you. Anyone else have any resources they'd like to share? I mean, we can always continue this conversation too. You guys at your provider meetings, sharing crisis resources. I think this is something that's super important for us to keep in mind, because no doubt our clients are going to experience crisis. So any questions, concerns, anything before we wrap up here? I see Kayla put in the chat box, Valley Community Health developed and provides cards to each participant that outline emergency resources, including 911, National Suicide Prevention Hotline, Crisis Text Line, and the Northeast Human Service Center Crisis Line. That's great. That's something kind of goes along. It's kind of a form of a safety plan or a crisis plan that you could easily give out to anyone. It's just super helpful information to have. I think even as providers, we need to have that information on hand for ourselves as well. So thank you, Kayla. Anyone else? No? All right. Well, thank you, everyone. Thanks, Lucretia. Thanks for everyone for joining. It's nice to see everyone participating, and we'll send those templates for the safety plans that we kind of came across with the suicide prevention hotline, just so you guys have that information, and hopefully you can apply it to your agencies. So thanks everyone. Have a great day.